Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
Well, hopefully you listened to our challenge last week, which was to make sure that you set up your yearly visits with your primary care physician, any other specialists that you see, and making sure you've set up things like your mammogram or any other screenings that you need to get done this year. We spent the last month talking about cardiovascular disease, and now we are really excited to transition into this month and cover a lot of women's health issues.
Woohoo! Woo. To start this month, we want to dive into a topic that is pretty hot right now. And the reason it is such a hot topic is for years and decades, we have ignored this topic and have not given it the attention that it needs. So today we're going to take time to talk about menopause and perimenopause and actually give you that evidence-based information that has been kind of ignored, as well as we have more evidence now for women, and hope that it only continues to grow to help us live our best life in our later years of life. And we're excited to bring on our guest today, Dr. Deidra Beshear, who is an expert in women's health and has worked at UK and the Women's Health Clinic. And recently, she started her own menopause clinic at UK. So we have lots of questions for Dr. Beshear today, and we're going to dive into this topic. But first, Dr. Beshear, can you tell us how you ended up in this path?
Well, good morning, guys. Thank you so much for allowing me to come and chat about menopause today. I started my journey in women's health during my internal medicine residency. I was part of the women's health track, so I had continuity clinics where I got to work directly with women. And then as I finished residency, I joined UK faculty in the Women's Health Clinic, which is a clinic that is devoted to providing primary care to women. After a few years of being in that practice, I decided that I was really interested in learning more about the menopausal transition and menopause in general. I felt like that was something I didn't learn much during my residency. I think most of us in medicine would say that was the case back a decade ago or so. So I did some training with it was at that time called the North American Menopause Society, which is now the Menopause Society. And they have a special track where you can become a menopause practitioner. So I completed that track years ago, but at the time I did not start a clinic. We had one at UK, Dr. Kathy Dillon, she's one of my mentors, and she was running the menopause clinic at that time. When she retired, there was no continuation of that clinic, and then COVID hit. So that was really not a top priority at the time. I went a few years ago to our director and asked if we could consider starting this clinic. My colleagues and I had noticed that, as you mentioned, this topic of menopause transition, perimenopause was really becoming very popular in the lay press. And we had so many patients inquiring, and we felt like there was a missed opportunity to treat these women within the UK healthcare system. So we were very fortunate that our department supported us starting the UK Healthcare Midlife and Menopause Clinic, and that's where we are today.
That's really exciting to know that people in Kentucky have that opportunity to come to UK and see someone that's specializing in that.
The official name for the menopause certification is the Menopause Society Certified Practitioner, the initials being MSCP. And you can go to the menopause.org website and you can actually put in your zip code to search for clinicians in your area that are certified by the Menopause Society.
That's great. I think that's a great tip if you're someone that's going to be looking for a new provider to help with this menopause or perimenopause, wherever you are in this phase, to really look for someone that's had that additional training, because we really did not get that in medical school and residency. And I think that's part of because there has been such an up and down opinion on hormones over the years. And I think at least during my training, we were in that time where it was hormones are bad, or there are more dangers to them than good. And then now the pendulum has shifted a little bit the other way. Actually, a lot.
Yes, absolutely.
Not a little bit.
Kidding. Yes, absolutely.
Maybe we should just start before we get into all of that, just with you telling us a little bit about what is perimenopause, what is menopause, and what are the symptoms that women have with these?
I think it's best to start by just defining what is menopause. And I think most women know this, but it's always good to review that menopause is the end of our reproductive age. So we stop ovulating. Once you have gone a full year without a menstrual cycle, you are menopausal. And so that average age of menopause in the U.S. is around 51 to 52 years old. Now, leading up to menopause is perimenopause, or otherwise known as the menopausal transition. And that can occur anywhere from 2 to 8 years prior to that last menstrual cycle.
We're going to pause there because I don't think many people realize how long that can last. So just to reiterate, 2 to 8 years. That's a long time.
It is. It absolutely is. And especially when you think that the average age for women to go through menopause, what is considered normal, can be anywhere from 45 to 55. So if you think back to if a woman is having her last menstrual cycle at age 45, she may begin experiencing perimenopausal symptoms in her late 30s.
And so how would someone know that they are in perimenopause?
When we're starting the menopausal transition, the first hormone that starts to drop is our progesterone. And this is our hormone that helps us with sleep. It helps us with mood. And so many women will start to notice that their sleep cycles are disrupted, that maybe they're more anxious than they used to be. Maybe they're a little more irritable. And many times that is the beginning symptom of perimenopause.
And how do you know perimenopause versus, let's say, being a busy mom with young kids and your anxiety's up just because of everything that's on your plate?
Absolutely, because it can be really hard. We know that this time in our lives, in our 30s and 40s, we are very busy, most of us with, families, children, parents that may be elderly, and we're caring for them as well as working. And it can be hard many times when we're visiting with a patient to know, is this just expected situational stress and anxiety associated with all of our demands that we have in life? Many times what we'll ask is, have you started to notice any change in your cycle pattern? Have you noticed that your cycles are still occurring every month, but maybe they're not as long as they used to be, or maybe they're longer? Maybe your flow is increasing, that you're having heavier cycles. And many times those are early signs that the menopausal transition is beginning. And that may help us to differentiate between that situational anxiety, stress versus perimenopause.
And in that moment, because I know this question gets asked a lot early in the menopausal transition, are there lab signs that can be picked up?
Great question, Dr. Cheeks. And somewhat controversial, but
yes.
There can be. I will say we don't usually follow labs because we know that during perimenopause, lab values can be all over the place when it comes to the hormone levels. So they really can fluctuate day to day. However, it can be helpful in select patients, especially if we don't know how often they're cycling, whether maybe they've had a uterine procedure that doesn't allow them to bleed, or maybe they have an IUD that they don't have menstrual cycles. That is when it can be helpful to get blood levels.
And so if someone is still having regular cycles, but maybe is seeing a little bit of change there, and they do have blood work showing estrogen is low, is that something they need to worry about? Should they talk to a doctor about that? Or is it just something they should kind of wait out, since potentially the next day it could be normal?
Exactly. Well, I would say we would base it on their symptoms. So if they are complaining of a lot of insomnia, anxiety, maybe even starting to have hot flashes, then we might want to consider treatment options for that patient. Sometimes we can just watch and wait. And as you said, Dr. Dotson, we can just recheck labs in maybe 2 to 3 months and get a better idea of where you might be in that menopausal transition.
So you mentioned starting, usually it's kind of noticing either a change in your menstrual cycle or a little more anxiety or a change in sleep. What are kind of the next symptoms people might experience as they go through this?
Well, as we go further along in the menopausal transition and we're entering into the later stages of perimenopause, that is when the estrogen level also starts to drop. And that's when we start to experience the most common symptom of menopause that most women are aware of is the hot flash. And the hot flash is really due to the estrogen loss. So many times women will start to notice that they're having night sweats or hot flashes. They also may notice this is the period in life where their cycles are really starting to spread out. They may go 2 to 3 months without a menstrual cycle. They may notice their cycles are becoming shorter. Or sometimes, unfortunately, some women, their cycles actually become longer. But usually there are skipped months where they are not cycling at all. And that really can help us to identify those women who are entering into that later perimenopause transition.
When you're headed towards that later transition and having these more frequent symptoms, we do start to notice a lot of these other that are not recognized by so many people as menopausal symptoms. Can you go over some of those? Because I truly think this is where, because this has been such a hot topic, women are able to recognize and make this connection. But for our own listeners, what are some of those other symptoms that come along at this time?
So, of course, as we mentioned, the most common symptom, and around 80% of women going through menopause will experience hot flashes. You know, if you're in that 20%, that fortunate 20%, then you got lucky. However, the other symptoms associated with the menopausal transition, along with hot flashes, maybe sleep disturbance, anxiety, it's actually an extensive list. As you said, many symptoms that in the past we were not so aware of. But now, as we have more data and understanding of how many estrogen receptors there are in our body and how our body responds to the loss of estrogen. So that can lead to brain fog. That can lead to low libido, vaginal dryness. It can even lead to musculoskeletal symptoms. Something known as frozen shoulder has been associated with menopausal transition. Headaches, dizziness, hearing loss even.
That's actually a new one to me.
Yes. Yeah.
And I remember you presenting about this as either a resident or a new attending. It just stuck in my brain. Could you talk about like the difference in someone who's either in that late transition of menopause or in full menopause, their concentration as well as their ability to learn at that time and the impact? Do you know what I'm talking about? Okay,
yes,
I was like, I remember this. I remember this slide. It's stuck in my brain forever. So could you please tell our listeners about that?
Yes. So when I see patients who are struggling with brain fog, I always like to share with them that there is evidence behind this. We know from studies that women taking standardized tests prior to menopause and during menopause and after, that their standardized test scores actually go down during the menopausal transition. The good news is they do go back to baseline following menopause. So we are not losing all of that. However, there is an absolute correlation with lower standardized testing scores during the menopausal transition.
See, that's why it's stuck in my brain forever.
Especially because most of us have to recertify around the age
yes,
of 50.
Exactly.
Well, I want to bring up one that I think is probably one that most women worry about, maybe the most, and that is feeling like it's more difficult to lose weight or feeling like they're gaining weight during perimenopause and menopause.
Yeah, so that is always hard to share that information with patients, that physiologically the majority of women do gain weight through the menopausal transition. The average weight gain is between 15 to 20 pounds, and that's without changing anything, without changing diet or exercise. That is what we're facing as we go through the menopausal transition. There is discussion in studies being performed to look at, is it actually menopause that's causing the weight gain, or is it just the aging process? More data is suggestive of the latter, that it is really the aging process, but we know that the hormonal fluctuations are not helping with maintaining a healthy weight.
Yeah. And from what I was reading about in preparation for today was that it really seems like the loss of estrogen causes certain fat cells in our body to want to work more and store more fat, like the fat in our abdomen, which is typically a less healthy fat, and the fat cells around our hips and thighs become less active or less going into that storage mode. Is that kind of the thought behind that?
Yes, that is correct. And that is what most women notice is the weight gain is more around the middle during this menopausal transition. And that maybe in the past when they would gain weight, it was more in the hips, in the buttock area. But now they are noticing that the weight is around the middle. And that is concerning because that, we know, increases our cardiovascular risk when we're gaining weight in our abdomen.
We do see changes in metabolic health for women in this transition. So what are some of those labs that may change for someone just because of menopause?
This is a great question. And I will say something I have been so surprised by in doing this midlife and menopause clinic is I knew that there was evidence behind the elevation in the lipid profile as we go through menopause in that year between the last menstrual cycle and completing menopause, but I had never seen it so dramatically as I have in my 7th, 8th month of running this clinic. Just this week had several patients that they have just recently gone through menopause in the last 12 to 18 months, and their previous lipid profile compared to what it is now has tremendously worsened, meaning that their total cholesterol and most importantly, their LDL cholesterol, which is the bad cholesterol, has significantly elevated. And like I said, we know that there are evidence-based studies to suggest this, but I have never seen it so clearly as now that I'm doing this clinic.
Yeah.
So for someone that, let's say, is really worried about their metabolic health, their weight, their cardiovascular risk, someone, let's say, that's led a pretty healthy lifestyle but has family members with cardiovascular disease, diabetes, and they don't want to follow that path, what do you suggest for them when they start noticing these changes?
I think it's really important to always have your baseline labs to see your primary care physician so that you have an idea of what your cardiovascular risk is. And that would mean with labs such as your lipid profile, your hemoglobin A1C, which is your 3-month blood sugar average, will be very helpful as you are going into this menopausal transition.
And is that ever an indication for someone to start hormones, let's say they weren't having a lot of issues with sleep or hot flashes at this point, but they were starting to see some changes in their cycle, changes in their blood work, changes on the scale. Is that a time that a woman would consider hormone therapy?
There is strong data to suggest that starting hormone therapy can decrease our risk of developing diabetes by 50%. And that data has been there for a while and is replicated, so it is strong. Now, as far as starting hormones for the prevention of diabetes in those patients that are higher risk, if we're following evidence-based guidelines, the guidelines would say that the indications for starting hormone therapy are patients who are symptomatic with hot flashes, patients who go through early menopause, and by that we mean women under the age of 45, women who have genitourinary syndrome of menopause, and that is described by vaginal dryness or pain with intercourse, and for women when we have some early bone loss and we're looking for the prevention of osteoporosis. Those are the main indications. However, we do know that women do respond very well to hormone therapy and have other added benefits. That would be a great discussion to have with a menopause specialist on whether the benefit might benefit you.
So it almost seems like, well, why wouldn't we just start it for every woman? You start seeing changes in your cycle, changes in your blood work. We're going down maybe a less healthy metabolic pathway. Why don't we start everyone on hormones? How has this shift changed over the years, and why is this topic so controversial for that?
Back in the early 2000s, there was a landmark study referred to as the Women's Health Initiative. And at that time, prior to the Women's Health Initiative results being released, we actually did start most women on hormones. I remember as a medical student and a resident in the late 90s, it was rare for me to see a woman over 50 who did not have hormone therapy prescribed for them for preventive care, for cardiovascular preventive care. And then, as you said, the pendulum quickly shifted once the WHI results were released in 2002. The Women's Health Initiative study at that time suggested that there was an increased cardiovascular risk for women on hormone therapy, a significant increase in heart attack and stroke. And therefore, most women their hormones were abruptly stopped. In addition to the cardiovascular risk that was seen in that study, there was also a noted increased risk of breast cancer as well. So this was new data at that time. Many women who were on hormone therapy experienced a very difficult time where they were not just tapered, the hormones were abruptly stopped. In retrospect, the average age of women enrolled in the study was around 65, and hormones were being started in these women at that time. Now, we know that the benefit for starting hormone therapy is really closer to the age of menopause. So if we can start a woman on hormone therapy within 10 years of their last menstrual cycle, further data has shown that is where we get the most cardiovascular benefit. Now, as we do get into our mid-60s, that is when the risk and the benefit ratio needs to be evaluated by a clinician and their patient, because that is where we do start to see increased cardiovascular risk, especially if a woman is starting hormones at that time. And we know that greater than 20 years since your last menstrual cycle, there is a definite increased cardiovascular risk. And those are women that we really would look for other options for treatment at that time.
My understanding of this, because it's kind of a difficult topic to understand, I think in medicine we tend to think, okay, you have this disease process and you have this treatment that helps, okay, we do it, we're done. But in this situation, it really seems like for some reason, and I'm not sure I fully understand why, the blood vessels, the cardiovascular system is benefited by estrogen in your younger years and even when your estrogen starts to go down in the beginning of menopause. But once you've been through menopause and you've had periods of time where your estrogen has already been low because of menopause, then adding estrogen seems detrimental and you have worse cardiovascular risk. But it's kind of strange to think just the timing of that makes a difference. But that seems to be the case. Am I understanding that right?
You are understanding that correctly. If there is cardiovascular disease, if there's atherosclerotic disease that is present, and we start estrogen, there is an increased risk of cardiovascular events.
And, of course, when you are 65, you're going to be much more likely to have cardiovascular disease than age 45. So,
Absolutely.
Being aware of that and making sure you're informed of that when you have this potential hormone discussion with your provider, I think is really important.
And then on the other part that you were talking about, can you tell our listeners about breast cancer risk and for those women who may be at higher risk or have that strong family history or may even have a genetic mutation that they know of that puts them at higher risk? How should they look at hormone replacement therapy?
Well, in referring back to the Women's Health Initiative results from 2002 and identification of an increased risk of breast cancer in patients on hormone therapy, I want to break that down to understanding that actually in the patients that were on estrogen alone, so they did not need progesterone, most women that would be that they've had a hysterectomy, estrogen alone, there was no increased risk of breast cancer in those patients. Actually, there was a slight decreased risk compared to placebo. Now, in the women who were on estrogen and progesterone combined, that was where we did see the increased risk of breast cancer. I think it is very important to note that the type of hormones used in the Women's Health Initiative study are not hormones that we typically use now. At that time, they were using more synthetic hormones, so it was conjugated equine estrogen and medroxyprogesterone acetate. That was the progesterone component. It is not common that we use those medications anymore, and we are not sure, and then there are a lot of studies undergoing with the use of the more bioidentical hormones, such as estradiol and progesterone, to see if that risk is applicable to those types of hormones. For women who have an increased risk of breast cancer, as you mentioned, whether they maybe carry a genetic component, they have family history, or maybe they actually have a mutation that puts them at higher risk. Those are patients that we don't want to say that absolutely they cannot go on hormones, but we need to have a very thoughtful approach to considering hormone therapy. Many times I will start that with reviewing their most recent mammogram and the results of their breast density, as well as calculating a breast cancer risk using a tool such as a Gale model risk calculator or something called the Tyrer-Cuzick or IBIS breast cancer risk model. Those risk calculators really help us to look at their family history, their personal history, and give us a percentage of their lifetime risk of developing breast cancer. So any woman with those risk calculators that scores greater than 20% of a lifetime risk of breast cancer, we know is in a higher category as far as developing breast cancer, and many of those women will want to undergo more frequent screening for breast cancer.
As a woman who has a family history of breast cancer, I know previously I had thought, well, there's no way I'll ever be able to take hormones. But now the data looks like actually taking estrogen and the right type of progesterone actually decreases your risk of breast cancer. So it's really a big mind flip for me, and I assume for a lot of other doctors that may be trained around my time to think, wow, actually that might even benefit me to take hormones. So I think it's really kind of hard to wrap our minds around. But one thing I want to clarify for listeners just hearing this and thinking about, well, how could that be? We don't think estrogen causes breast cancer. But if you have breast cancer cells that are small and haven't been able to be seen on mammogram yet, hormones could fuel them to maybe reproduce or grow faster, and then we may catch it on the next mammogram.
Yes.
Is that kind of how you think about
it?
Yes,
absolutely. That is what we understand now. Estrogen does not cause the breast cancer, but if you already have a higher risk or an early breast cancer with the addition of hormone therapy, especially if it is a hormone receptor positive cancer, it can be like adding fuel to the fire. Yes.
And that's why it's really important when you're making these decisions of hormone therapy or not to have a provider who is experienced and understands the difference in these risks to help you make the best decision for you, so they can tell you about your personal risks, understand and make sure you've had all the appropriate screening, because it's really easy to just generalize these things and assume everybody's okay, but that's not really the case. So we really want our listeners to understand, if you do fall in one of these buckets, it is crucial that you end up in the right hands of a provider who knows what they're doing, so you have the correct information to help make that decision for yourself.
Yes, absolutely.
And to be getting your mammogram.
Yes, absolutely. And I think that really there are so many women, as you mentioned, Dr. Dotson, that just thought that hormones would never be an option for them based on maybe their family history. And as we know, that is not the case. And it's just in meeting with that clinician who is well informed about menopause care and having shared decision making that you can move forward with the best decision for you.
Yeah. And I think one thing to think about, because as you mentioned in the WHI study, it looked like it was probably the type of progesterone used that was likely linked to that increased breast cancer rate. There are so many different types of hormones now, and I think it can be really confusing. I see one person with a patch, one person with a cream, one person with a pill, one person saying they have synthetic hormones, one person saying, well, bioidentical is the only way to go. I think it can be really confusing. Can you talk a little bit about what are these different types, maybe both what's the difference in synthetic and bioidentical and conjugated, as well as the different delivery systems, pill, patch, cream?
Yes. I think the best way to start this conversation is just talking about what is bioidentical. I think that many of us, when we hear the word bioidentical, we think that maybe would have to come in a compounded form. But there are many FDA-approved bioidentical hormone options for us. And as a menopause practitioner certified in menopause care, that is always our go-to first, is to choose the FDA-approved bioidentical hormone therapy options, because we know what is in them. We know that what we are prescribing is the amount that we are hoping that they are receiving. Not that we don't consider compounded bioidenticals. There are certain cases where that is the best option for the patient. But for the majority of patients, looking at FDA-approved bioidentical hormones is the best. And what bioidentical refers to is it is just a form of the hormone that is as close to what our bodies were producing as possible. So the estrogen form of that is called estradiol, and the progesterone form is progesterone. Now, on the other hand, synthetic hormones We talked a little bit about in the WHI, the synthetic estrogen was conjugated equine estrogen. So most people have heard, this is horsemear urine concentrate. And then there are synthetic progestins, which was medroxyprogesterone acetate.
So bioidentical really just means the form of the estrogen is identical to the chemical structure of the estrogen in our own body. But all of them are somehow synthesized in the lab, I guess.
Yes, they are. Even the bioidentical. Yes.
And so then how is it different in the form of a pill versus a cream versus a patch?
A lot of the decision-making in what form of hormones a patient takes would be between the patient and the provider. For most of us, we prefer to use estrogen transdermally through the skin. Observational studies have shown that if we can use estrogen through the skin, whether that's in a patch form or a gel or a mist, that may decrease our risk of blood clots, what we call thromboembolic events. So for most women, we would like to start with transdermal estrogen. Another benefit of receiving estrogen through the skin is that there has been less association with the formation of gallstones, as well as decreased triglyceride levels, which we can see with oral estrogen.
Now, is there someone that the patch is not a good option for that would make you consider using a different preparation?
So our patients who, if they are very active, especially if they are doing a lot of swimming, saunas, hot tubs, the patch may not be the best option because we're worried about adherence. So for those women, I will try a gel that they can apply daily, and the fact that they're in water or they're sweating often will not affect their absorption.
So does that, when you use the gel, you absorb it pretty quickly?
Yes, within 15 to 30 minutes of application.
And
right.
then you can hop in the
then
pool
you can
and you're
hop
good to
in
go.
the pool, get in the sauna. Absolutely.
And when would an oral estrogen be the preferred option? Is perimenopause, is oral preferred in perimenopause, or when do you usually use that?
There are some women that really just don't absorb estrogen well through the skin. And as I said, in my practice, I always start with transdermal estrogen. I try to. But after 6 to 8 weeks, if in our return visit, a patient is saying, I'm not noticing any improvement, I may check a level, an estrogen level, estradiol level. And if it is low, that tells me that they're probably not absorbing well. So that might be the ideal patient to switch to an oral form, to make sure that they are getting the amount of estrogen they need.
So in this situation, labs can be very helpful. I just clarifying that for a listener, because as we mentioned earlier, when you're in that early perimenopausal transition, sometimes labs can just be more confusing than helpful depending on the patient. In this situation, it can be very helpful just to understand, is it doing its job?
Absolutely. Is it doing its job? And do we need to pivot and look at other options?
And so if the patient came back and said, oh yeah, I'm sleeping, I am not changing the sheets 2 times at night because I'm sweating, you would just stick with what you're doing and not necessarily need to keep rechecking levels if it's working well.
That's right. Yes, we'll follow the symptoms. And if we have resolution of symptoms, then I think we're on the right path.
Who needs progesterone?
Most women, if we have a uterus, we need progesterone. I like to explain the reason that we need progesterone kind of like a yin and yang, the estrogen and progesterone. Estrogen can cause our endometrial lining, our uterus lining, to get really thick. And over time, if you're on estrogen alone, that can lead to that endometrial lining having atypical cells. And worst case scenario, that could lead to endometrial or uterine cancer. What progesterone does is it helps to balance that out. It helps to keep that endometrial lining really thin so that we're not at risk of developing those atypical cells, which could lead to uterine cancer. So if you have a uterus, you will need some form of progesterone. And that could come if we're thinking of different forms of, we talked about the different forms of estrogen, different forms of progesterone. The main form that we use is oral. We can use a bioidentical FDA-approved product called Prometrium, which is a capsule that you can take at night. There are some synthetic progestins that you can take orally as well. And it is off-label here in the U.S., but in Europe and Australia, it's very common to use a progesterone-secreting IUD, such as Mirena IUD, for that progesterone protection, that endometrial protection.
you're talking about progesterone's use for reducing that risk. Is there additional benefit in symptom management of menopause by being on that progesterone?
Yes, there can be. So for women who've had a hysterectomy where we don't necessarily need to start with progesterone, if they come back and say, I feel like my hot flashes are better, my night sweats are better, but I'm still not sleeping great. My mood is still a little off. Those might be women where we would want to consider a trial of progesterone because that really does, as we spoke earlier about the effects of progesterone, it really can help with mood and sleep.
And for someone that just does not want to take hormones, let's say, or does have known cardiovascular risk and doesn't want to go down the hormone route, are there other options to help with these mood issues and to help with the hot flashes?
So we're very fortunate. There has been a lot of movement with non-hormonal options for women over the past few years. Many times we will start with a medicine that many patients are familiar with called SSRIs, which are used for anxiety and depression, but that is a nice option for non-hormonal treatment to help with hot flashes, to help with mood. So for those patients that can't take hormones or choose not to, that might be an option. There is also a new medication that most people have probably seen in the news on ads called fezolinetant or Veozah. And so this is a very exciting new drug that works better than anything we've had for non-hormonal products for vasomotor symptoms. And it works on the thermoregulatory center of the brain. So it actually helps the brain to decrease the threshold for where we have a hot flash. So it's much less likely that we have hot flashes. It's still not as good as hormone therapy, but it is a great new option for women who can't take hormones. That is something that if you're going to be prescribed Veozah and start that, you need to follow closely with your clinician where it is a new medication. There's some lab testing that needs to be followed closely for the first year.
And I'm glad you brought that up. How is coverage insurance-wise for most of these things? I know in my practice previously, especially with postmenopausal women and trying to get estrogen patches, that was usually not well covered and was just not a financial option for a lot of people. Is that still the case? Are we seeing any improvement there?
I think there has been some improvement. It is a rare occurrence where I will have a patient on Medicare that the coverage refuses a vaginal estrogen. So that is good news. But you're right. I think the struggle can be in patients who are not on commercial insurance in the coverage of systemic hormone therapy still.
And you did just mention vaginal estrogen. Can you explain where that specific application is very helpful, as well as some of the genital urinary symptoms that also I think is something that people don't make that connection?
So vaginal estrogen is really used best for those women who do have genital urinary syndrome and menopause. So that is a long term that really encompasses women with vaginal dryness, pain with intercourse, patients who are experiencing more frequent UTIs. That if we can start vaginal estrogen, we know we can really help to lessen those symptoms. The other thing about vaginal estrogen that is important to note is it is just a local effect. So even for those women who have been told they can't take hormones, most physicians feel safe in prescribing vaginal estrogen because we know it is not getting in the bloodstream. It is just a local effect on the vaginal tissue.
Is that specific preparation less risky as you age as well?
Yes, it is. It is. So vaginal estrogen, we tell women you can really continue that for the rest of your life. And most women probably should, especially as more studies are coming out showing the improvement in risk of recurrent urinary tract infections. And we know that in elderly women, a significant cause of hospitalization and mortality is urosepsis.
Yes, I know that's something that I definitely saw in practice and had many patients benefit from starting that preparation of estrogen, and it truly reduced their UTIs substantially.
Yes, absolutely.
It's not something that everyone talks about, but it's a great benefit of it.
It is. Yeah, it really is. Before we move on to talking about lifestyle change, which I want to make sure we get to, of course, can you go back to when you're transitioning from perimenopause to menopause and how that might change your hormone replacement if you're doing it?
Many times women will be on like a low-dose birth control pill during the perimenopause transition, especially if they're having heavy cycles or irregular cycles. And for those women, what we suggest is As you get closer to the average age of menopause, say around 50 to 51, the only way to know for sure if you've transitioned into menopause is to actually stop the birth control pill for a few months, and then we do check labs. That would be the best time to see if you have transitioned. And if it does appear that you are now menopausal, if you are symptomatic, then we can transition to hormone therapy.
Now, if you stopped your hormones and you weren't having periods anymore, it does seem like you've been in menopause, but you're not having hot flashes, or let's say you feel decent, would you recommend doing an estrogen patch at that point, or would you recommend just watching and waiting?
I think it all depends on the patient and what their goals are as they are going further into menopause. Many times in those patients, I do like to get a baseline bone density scan because, as we mentioned, if there is some early bone loss, we know that hormone therapy can be very beneficial for those patients.
And for patients, maybe they have an IUD. They have no idea what's going on with their cycles as well. In that situation, is there a specific time that you recommend women who possibly have a hormonal IUD to, not have it replaced the next time and see where they stand? Is it the same age that you recommend for the oral contraceptives?
Well, the good news about women with hormonal IUDs is that will not adversely affect our blood levels to show us if you're still ovulating and your estrogen levels. So that we can still check those labs and have a good understanding of where you may be in the menopausal transition. And I tell women, if you really like your Mirena IUD and you're entering into menopause and you're due for an exchange, maybe consider doing that, because I really do like to use Mirena IUDs as the progesterone component or endometrial protection for a lot of women as they move into menopause, and we may need to add estrogen.
Just to clarify, to make sure everyone's clear, so what is the benefit of going from that low-dose oral contraceptive birth control to hormone replacement therapy with, say, a patch or an oral progesterone? What actually changes there and why?
Great question. I get this question almost daily. So the type of estrogen in birth control pills is called ethinyl estradiol. It is a very potent estrogen because it has to stop ovulation. It's providing contraceptive management. The type of estrogen we use in hormone replacement, mainly estradiol, much less potent, but still very effective at controlling the vasomotor, the hot flash symptoms. And we know that the ethinyl estradiol, because it is so potent, it does carry more risk in staying on that type of estrogen that's in birth control pills. So it is a recommendation that by the age of 55, that most women have transitioned off of birth control pills and transitioned onto hormone therapy for that reason.
And I think another great point for listeners and women in general, there's many women that hate how they felt on birth control and have stopped using it over the years just because they didn't like what that potent estrogen feels like. Do they have the same feelings or experiences they have when they switch to a patch, though?
I share with most women that even if you did not tolerate birth control pills, that it's worth trying hormone therapy with the estradiol because it is less potent, that they may not experience any of the side effects that they had when they were using oral contraceptives.
And I think that's really important because I think that's confusing, right? There's, in practice, there are so many times I've heard women that just I do not like how birth control pills make me feel. And so it makes you really leery about trying something later in life. But we just want you all to take away that it's not the same potency.
The other thing to think about is part of the problem, my understanding with perimenopause, part of the problem why you might feel a little wacky, a little more irritable and have some of these symptoms is that there's some days where your estrogen is low, and then there's some days where your estrogen is probably higher than it was even in your 20s. And that maybe the low-dose birth control kind of shuts your ovaries off because it takes over and so makes you more level. So it might be, even if you're someone that didn't think you felt well on it back in your 20s and early 30s, it might actually be something that you would feel better on just because you've had more stable estrogen levels even in perimenopause.
Yes, absolutely. I think there is definitely a role for the use of low-dose birth control pills in the perimenopausal period. I know that a lot of patients, I think there's a lot of discussion in social media about whether that is the appropriate treatment for perimenopause, and it's not a one-size-fits-all. But I do think for women who have very heavy cycles, who are having what we call those loop phase cycles, as you described, where you have really high estrogen at times, which can cause you to feel very symptomatic. You can feel like if you've been pregnant, it feels like you're in your first trimester of pregnancy. You have breast tenderness, you're really moody, maybe you're even feeling like you have morning sickness. If you're having frequent episodes like that, a low-dose birth control pill might be a nice option to help get you through that menopause transition.
We talked about non-hormonal options. I see a lot of supplements, black cohosh, red clover, one called Hormone Harmony that I had a friend really love. Is there much evidence behind trying these? Is there any harm in just trying them, or what do you think?
So there's not great evidence to suggest that herbal remedies can be helpful. However, I have several patients that feel like their over-the-counter supplements have really helped them and may be helping to get them through the transition without adding prescription hormones at this time. I would say if there is some evidence around black cohosh, and you will find that that is in a few of the over-the-counter, more popular over-the-counter supplements. I always tell patients it's probably not going to harm you to try it, but you do need to review your medications and your risk because we know most of these are cleared through the liver. So if you have some underlying liver disease or you take several medications that are cleared through the liver, you might be at increased risk from taking some of these over-the-counter supplements.
And that's one piece of advice I always tell people who are on supplements, even if they are low risk. It is always crucial to let your providers know that you're taking them because they can have lots of drug interactions with something else that you may take and then make them harmful or make the prescription medication have a higher risk in general because of the clearance, etc. So if you do consider this, always remember this should be on your med list so your providers know that you're on them.
And how about any recommendations in regards to diet and exercise?
This is really where we should be focusing on for our women who are coming in their 40s and 50s. What can we do for lifestyle and diet to help get them through this transition as healthily as we can? We do know that for women, when we're looking at diet, if we can focus on more of a Mediterranean diet, really focusing on those lean proteins, our complex carbs, fruits and vegetables, that this type of diet really benefits us as far as the cardiovascular risk that we see as we transition. We also know that for exercise, we are losing muscle as we go through menopause, something called sarcopenia. So if we can focus more on maybe more resistance training in our exercise. So this is not good news for people like me who are cardio queens, that I need to add some weights and resistance. It's not that I have to go to the gym every day, but it is really important to start focusing more on resistance training as we're going into menopause than it was before.
And I know this is something that I work with patients on a regular basis with is talking about these dietary changes because, again, as we mentioned before, women who have literally changed nothing in their life, they've been able to maintain their weight, but when they go through this transition, suddenly weight starts increasing. We have to change it up. There has to be a change in your routine, etc. Even being on hormone replacement therapy, a lot of times you're going to have to adjust your lifestyle as well to help manage that weight component that occurs. And so I love using the Mediterranean diet. I think it's just one that is very well balanced. And many women over their lifetime have lived a very restrictive type diet when they are trying to work on weight loss and not focusing on the balance of what they're eating. And that's something that really is important in menopause is taking the time and learning how to balance your food, making sure you're getting enough fiber, making sure you're getting those protein goals because your metabolism is changing, your muscle mass is changing. And so these things are needed in order to have, successful either weight maintenance or to work towards that weight loss that you may be trying to reach.
And I saw the ongoing study, the Women's Healthy Lifestyle Project that's going on that looks like making a lot of these lifestyle changes if you do it and stick to it, when they looked at the women that made them versus those that did not, it did seem to prevent the projected weight gain and the change in waist circumference and things.
Yes, absolutely. So I think it's really key for women to start thinking about. We talked about when can perimenopause start. It really can start in our late 30s to early 40s. And if we really try to start making these lifestyle modifications early, I think we'll be much more successful as we get close to menopause.
I joke with people. I was also a cardio queen, but one of my motivators. I have many motivators for weight and resistance training now, but one of them is that preparation. Being like, I know I need to work on building this habit because it's going to be crucial through menopause. So if you're in this age group, realizing that this is a great time to, if you don't have that habit, to start working on building that habit because it's only going to help you in the future.
And one thing I feel like I see in the media is kind of this advertisement of hormones will make your life perfect. If you're struggling as, in midlife as a woman, just take some hormones and life will be great. But what can women truly expect? What should their expectation be if they were to start hormone therapy?
Yes, I wish it would fix everything. I really do. But unfortunately, there are so many factors that go into how we feel in midlife. And so, I always share with women that if we're going to try hormone therapy, if we're going to start hormone therapy for the symptoms they're experiencing, then we want to at least give it a good 6 to 8 weeks to see if we're improving the symptoms that they came in with. Now, for some women, we might want to do even longer depending on the type of hormone therapy we choose. It may take 3 to 4 months. But many times women will say, this might have helped with my sleep. Maybe it helped with hot flashes, but it really didn't help with the brain fog. It didn't really help with the anxiety. So it's not to say that hormones aren't going to help that. It's just maybe we need to look at other areas that might be more beneficial.
So when you're going into thinking about hormone therapy, make sure your expectations are realistic and really make sure that you're talking with your doctor about what your personal goals are. Sometimes as doctors, we're just making guesses because we haven't really clarified with patients. So, if your biggest fear is your bone health and your cardiovascular risk, make sure you convey that to your treating provider. If your biggest worry is your weight and that you feel like you're losing your temper more frequently, then that may take them down another route as well. So just starting hormones is not going to blanket cure all your symptoms. So make sure you're clear about what you're hoping to get out of it so that they can maybe give you the best expectations and the best treatment.
Yes. Absolutely.
And we never want, because a lot of times in this age group, we want to blame almost everything on menopause. And we don't want patients to have a condition or a symptom that's not appropriately screened for other conditions as well, because that's really easy to happen to women at this time. Be like, oh, that's menopause, that's menopause, that's menopause. And we should have had more appropriate screening for, if you have a sleep disturbance, let's make sure you don't have sleep apnea. Or if you are having some challenges with your mood, we don't want to miss a diagnosis of depression or generalized anxiety disorder. So it's really being open and having those conversations with your provider to make sure the full evaluation is occurring for what symptom you're trying to target.
And I know we've got to let you go soon because you have women anxiously awaiting you to help them with these symptoms here in a minute. So I feel like I'm seeing more and more about testosterone. And so I trained in the early 2000s when WHI had already come out. And so we'd gone from giving everyone hormones to no hormones. And then testosterone has kind of emerged on the scene. And that really alarmed me. I felt like we don't have any data. What are these women doing? Getting testosterone pellets. And now I'm seeing more data that is calming me down about that a little bit, but I still feel a little uncertain about where we are with testosterone. Can you update us on that?
Yes. So there is an indication for testosterone use in women, and that is for the use for hypoactive sexual desire disorder or low libido. Topical testosterone is an indication for this problem. Many women do notice, along with improvement in libido, that they have less brain fog, that they have improved mood. However, the evidence really doesn't suggest that we use testosterone for those reasons. So in my practice, if a woman is having issues with low libido, then I think it's very appropriate to try a testosterone product. That being said, there is no FDA-approved testosterone product for women in the United States. There are some in Australia, but not in the U.S. So if we are going to use testosterone, we will work with this is where compounding pharmacies can be very helpful. And I have several compounding pharmacies here in Lexington that I work with their pharmacists to find the best product for our women. And it usually comes in a testosterone cream, and that is something they would apply daily. And then we would recheck their testosterone levels. This is also where labs are important because testosterone levels have to be followed closely in women. So we would want to get an initial level to see where they are with their testosterone level before starting, and then within 6 to 8 weeks want to recheck that because we don't want to have super therapeutic levels of testosterone. That could lead to side effects for women such as acne, facial hair, male pattern balding, voice changes, even enlargement in the clitoris, and some of that can be non-reversible. So we have to be very cautious in using testosterone with women.
How about in the form of pellets?
Some women do choose to go with testosterone injections or pellets for testosterone replacement. Just note that if you use that form of testosterone, we can see very high levels and very fluctuating levels. I will say many women do feel better initially when they start that form of testosterone because they are going from probably a very low testosterone to pretty quickly a very elevated level. However, I have seen some adverse effects in my clinic, so my preference is to stay with a topical form of testosterone that they apply daily. That way, if we're running into adverse effects or elevated levels, we can easily stop it or adjust the dose. The problem I have with injections and pellets is once they are in, they are in. So if you have pellets placed, they can be present, that drug can be present in your system for 3 to 4 months. If you go tomorrow and you get a mammogram that shows you have a breast cancer that is a hormone receptor positive breast cancer, I can't go in and take those pellets out. Your breast cancer will be exposed to hormones until the pellets run out. I don't want to scare anybody. I know there's great benefit, and there are some of my patients that really benefit from pellets. It's not something I choose to prescribe, but I do want our patients to be informed.
And I think that's what is important when anyone receives treatment is just to understand benefit versus risk. That's our job as physicians, is to always go over that information. And so I think that is a great explanation of understanding what risk can occur with that specific formulation.
And so potentially for a woman, let's say, that has done hormone therapy in perimenopause and menopause and has done exceedingly well, has been very happy with how they have felt, has transitioned well, is there a time where you say, okay, party's over, time to stop?
Well, good news is we don't have to say that anymore. We have evidence to show that for many women, you can continue hormone therapy into your 60s and 70s safely. It really is something, though, that needs to be evaluated on an annual basis with your clinician to look at your risk and benefit ratio. And we can continue that. I have some women, they're in their 80s and they are not giving up their patch. They feel like their quality life has improved. And then we look at their risk and benefit, and I just make sure that we're on the same page with our understanding. And if they want to continue, then we will do so.
And for someone that is going to stop hormone therapy, is that something you do? I mean, I think obviously if you have a hormone-sensitive breast cancer, you're going to stop that abruptly. If you're just stopping it because you want to do that, is that something you should taper down? Is that something a patient can just stop and then not come back to see you? Or how would that go?
Yes, if you make the decision to stop hormone therapy, I recommend that you taper. I think for most women, tapering decreases the chance of having worse symptoms. Now, it is common that women will experience some of the symptoms that led them to start hormones altogether. However, if we slowly taper, say we go down on the dose over a couple months, most women do very well with that, rather than abruptly stopping.
Speaking of that, you brought another question to mind. For a woman, let's say, that did not do hormones and had pretty severe hot flashes in her mid-50s, how long can she expect that to last? Is she still having hot flashes at 70?
Well, as we said, the majority of women will have hot flashes, up to 80%. Out of that 80%, there is 10 to 15% of women that continue to have hot flashes into their 70s and 80s, unfortunately.
Oh.
So, those are patients where I know we talked about the timing hypothesis, and it's really the most benefit to hormone therapy is starting 10 years after their last menstrual cycle. But if they were women who, were at the time they were going through menopause, that hormones were not an option for them, then maybe we revisit that and we look at the risk and benefit of maybe initiating even if they are 15 years out, but if they are so symptomatic.
Because we know, especially if disrupting sleep, that's going to impact all sorts of things.
So something that I feel like sometimes is left out of the education when it comes to menopause treatment and kind of understanding your symptoms, etc., is, let's say you are a woman who has already gone a year, have not had a menstrual cycle. You're started on hormone replacement therapy, and then 6 months, a year, or even 2 years later, you have a cycle again. What should you do?
Yes. I always like to tell women when we start hormone therapy that it can be normal to experience some vaginal bleeding up to 6 months of starting hormone therapy. So in that 4 to 6 month period of starting hormones, if you have some vaginal spotting and some bleeding, now we're not talking heavy bleeding like the first 2 days of a menstrual cycle, but some spotting, light bleeding can be expected and is not an indication for further evaluation at that time. However, if we have gone past that 6 month point of being on hormone therapy, and I should also say that not just starting hormone therapy, but if we've made adjustments to hormone doses, we can also see some breakthrough bleeding at that time. And so we can allow for that, up to that 4 to 6 month time period. Past that point, we really need to be considering the possibility that there might be a problem that we need further investigation. So in those women, I would go ahead and get a transvaginal ultrasound and look at the endometrial lining, because we talked about the risk that lining could get too thick. That many times is the reason for the bleeding in hormone therapy. And then that may lead to an endometrial biopsy to make sure that we're not seeing any atypical cells. But it is something that does not need to be ignored, especially if it's past that 6 month point.
We just want to make sure our listeners understand that, because I do feel like that is not talked about enough. And because you can have that spotting that occurs with dose adjustments or starting in general, that many women will just ignore it if it happens later, thinking it's just, oh, well, I'm on hormone replacement therapy, no big deal. It can be a big deal. So just be sure you're communicating those changes with your healthcare providers so you all can get the appropriate workup if it's needed.
Obviously, you have a lot of knowledge in hormones and treating this phase of life for women. How can someone come see you? Are you booked out 2 years? And are there any other options?
Well, as I said in the beginning, we are so fortunate that our department supported us restarting this clinic. Our availability has been tough.
Sarah, maybe we should go ahead and book for when we're...
I know. I should say. We have added another clinician, one of my colleagues, Erica Marnati. She is one of our nurse practitioners in the Women's Health Clinic, and she is also working with me in a menopause clinic. So we have better availability. We are also looking to expand. So if you want to schedule with us, you can find us on UK Healthcare website. You can also call us at 859-323-3900, and we'll hope to continue to add clinicians so that we can add more patients. We accept all insurance plans that are accepted by UK Healthcare, so our goal is to offer affordable midlife and menopause care to our patients.
Are there any good online resources for patients to seek out that are wanting to learn more?
Or even books?
Yes. Well, I would start with the menopause.org. So it's not just a great website to find a menopause practitioner, but also so much information about menopause for patients on that website. There are a few books that I myself have enjoyed reading that I think patients would. A New Menopause by Mary Claire Haver. I think she gives a really nice review of the menopause transition. I also recommend a book by Dr. Heather Hirsch, Unlock Your Menopause Type. There is also a book if we're thinking about sexual health that is You Are Not Broken by Dr. Kelly Casperson as well.
She has a great social media account.
Yes, she does. She does. And she's just fun. I've met her at several meetings.
Very entertaining. So any of our listeners, you should check out her social media as well.
Well, this has been so informative. Thank you so much, Dr. Beshear.
Oh, well, thank you guys. It's so nice to see you both and to chat about menopause transition.
So that was so much great information. I think the big takeaway is that our hormone health affects us in so many different ways. It's not just hot flashes and sleep. It's not just feeling irritable, but it's also our bone health, our breast health, our genitourinary health, our musculoskeletal health. And so hormones affect our body in so many different ways. And there are a lot of types of hormones, and everyone has their own unique risks as far as their own cardiovascular risks, family history risks, bone loss risks. And this is a very individualized field of medicine. So make sure that when you meet with someone to talk about the potential of using hormones, that you are thinking about what are these aspects of your health that are most important to you. Make sure that you're conveying that clearly to your provider. And then make sure you're talking about all of the different options, reviewing what would be the risk and benefit of an oral combination, which estrogen would be the best at reducing my breast cancer risk, which estrogen would be the best at minimizing a risk of clot, and go through these options. Make sure you understand that the combination of hormone therapy that you're getting is best suiting your needs, and you're not just being given a prescription for the same patch and cream that everyone is getting. Make sure that your provider understands your needs, your concerns, and then make sure you're following up well to make sure what you're using is working for you.
We have talked a lot about nutrition because that's what we do. We're lifestyle medicine doctors. But we just want to, again, emphasize the important, we talked about last month, of what our diet does for our cardiovascular health. And here we're talking about menopause. And again, we're talking about how important our nutrition is for this time in our life as well. So because of that, we want to bring up our challenge for the week. And really, this one's a tough one. So if you're up for it, I am super excited for you to do it because it can be very eye-opening. We, in these different diets that we've talked about here recently, most of them provide a very high fiber diet. And when people are trying to increase their fiber for whatever reason in their diet, most of this is coming from their fruits and vegetables. And if you're trying to find a unique way to increase those, we really want to push you to try the 30 different plants in a week challenge. This is something that Kitty loves.
Love it.
And I've had many patients do this challenge and also find enjoyment out of it just because it gives them something to focus on to increase that plant diversity in their nutrition. Again, when we can get fiber from many different plants, that's even better than getting all of our fiber from the same source. So this week, try it out. See if you can eat 30 different plants. That does include those nuts and seeds that you are using, your fruits, your vegetables. Go to the grocery, look around, pick up different options that maybe you haven't had before, and try to get in those 30 different plants. And once you build this habit of doing it, it gets much easier. But that first week, it definitely is a challenge.
But remember, if you eat some walnuts and you eat some almonds, those are two different plants. So I think if you really push yourself to look at what you're doing, you'll find that you can do it a little more easily than you think. Of course, if you haven't tried the hemp seeds yet, give those a go this week. But use those seeds, use nuts. Combine your vegetables and fruits in a different way. And I really think you'll find that this is a fun challenge.
Awesome. And we're super excited to continue this Women Health Month. And next week, we have a special guest, Dr. Elizabeth Elkinson, who also practices as an OB-GYN here in Lexington, Kentucky. She's going to come talk about PCOS. I know this is, again, a diagnosis that does not get a lot of time or attention in many different doctor visits. So we wanted to have a dedicated show for patients that may have this diagnosis or concern that they, possibly do, and go into detail about it with a specialist. So if this is something that you're interested in, please tune in next week to hear her show because it's going to be fabulous.
And as always, please leave us a review on Apple or Spotify. We would love to hear your feedback. So click on that link that says send us a text and let us know anything else that you're hoping to hear from us.
All right. Have a good week.